Lots of stuff going on this year, and what I'm going to try to make a brief review of what I thought was probably relevant. So look at something on preventive cardiology, lots going on heart failure. I got a couple of studies in interventional cardiology, lots going on in AFib, and of course, COVID-19, and what I've called a deconstruction of science and evidence based on all the pandemic responses we've had, even to interpretation of evidence. So I think it's important to just talk a little bit about that. I'm going to start with the TIPS3 study, which is a study from Salim. This is a study using the polypill for primary prevention of cardiovascular disease, the TIPS3 study. This was mostly done in Malaysia, Colombia, and some other country, and I'm forgetting right now. So basically 3 countries. And basically what they wanted to show was whether a polypill would reduce the composite of cardiovascular events compared to placebo. Now, this was a double factorial design, typical of the McMaster group, in which aspirin, they know that reduced the composite of cardiovascular death, MI, stroke, compared to a placebo, and the polypill plus placebo would reduce the composite also of cardiovascular events compared to double placebo. Now, major cardiovascular events were cardiovascular death, non-fatal stroke, non-fatal AM, heart failure, and resuscitated cardiac arrest or arterial revascularization. Now, as you know, there's been a lot of controversy for primary prevention with aspirin. So it's an interesting factorial design that patients were randomized to either polypill or placebo, and then randomized to aspirin and placebo, or aspirin and placebo plus the polypill. That was basically atenolol 100 milligrams, ramipril 10 milligrams, hydrochlorothiazide 25 milligrams, and simvastatin 40 milligrams a day, plus a low dose of aspirin with or without placebo of 75 milligrams a day. Now, this population is a population typical for this, about 5,000, over 5,000 patients. So it's a large trial, about 63 years. Almost half and half the population were female with hypertension or systolic blood pressure greater than 140 millimeters of mercury, with diabetes or glucose greater than 126, was about a little bit over a third. Not a lot of smokers, and with a total cholesterol and LDLs that you can see there, with the mean inter-heart risk score of 18, which is equivalent to an intermediate Framingham risk score. Now, the primary outcome, again, there was just nominally statistically significant, about a 20% reduction, relative risk reduction in the primary outcome, with reduction in cardiovascular death, MI, and stroke. Again, that did not reach statistical significance, but trended in the right direction. Primary plus angina and first and recurrent primary events, whereas about a 24% relative risk reduction, with a 10% relative risk reduction that again did not achieve statistical significance. When they looked at cardiovascular death, again, trending towards being statistically significant. MI, stroke, cardiac arrest, and revascularization probably was about a 50% reduction in revascularization that did reach significance. Now, what was interesting here is that, again, double placebo, obviously, he had a significant amount of events, but the population that received the polypill plus aspirin did better than those that had aspirin alone. So again, the discussion raised whether, you know, an intermediate risk population over almost a 5-year follow-up, there's a 21% reduction in cardiovascular outcomes, 14% with aspirin alone, and cardiovascular death, MI, or stroke. But the combination was a 31% relative risk reduction. Now remember that these trials were designed with an intention of having a reduction of about 50%, which was not achieved. Now again, the slides are not shown, but bleeding was very low, mostly because it was a dose of only 75 milligrams. So benefits are larger, about 40% with the polypill plus aspirin. in those that did not discontinue the medication because of non-medical reasons. And again, revisiting the role of aspirin in primary prevention, probably important in this kind of population. So food for thought there. So I guess, you know, I decided to restart my aspirin and take it with my blood pressure pill and my rosuvastatin. I don't know. Let's see if I bleed or not. You will always know. So this was published in the New England Journal recently by the TIPS guys. A lot of noise with this trial, the N of 1 trial of statin, placebo, and no treatment, because one of the major issues with this with these treatments are that people have pains, and you know, I guess 10 years ago when I started statin, I stopped it because I'm a runner and I felt that I was having a lot of muscle pains. The bottom line was this called N of 1 trial. So basically people would receive a statin, they would receive placebo or no treatment. The reality is that this, you know, although it's called an N of 1 trial, the way it ended up panning out, it wasn't an N of 1 trial because of some methodological issues. So it was basically reported as a, you know, statin placebo trial. Nonetheless, it does show that, you know, there's a significant placebo effect. And you can see here to the right, the patients who did not complete the 12-month trial, the patients that did complete it, you know, this is all over the place. So basically concluding that, you know, most of the effects of myopathy probably are not that realistic, and that a lot of these patients should be staying on the statin and taking the statin. So an interesting design and interesting conclusions. A lot of noise also with this trial, the strength trial. Again, omega-3 fatty acids versus corn oil on major adverse events. As you know, the reduced trial did show a significant reduction in cardiovascular outcomes. But this trial, it was about 3,300 patients, and about 33,000, were screened, and 1,300 were randomized. So it's a large trial, almost 7,000 patients on each arm. Now, lots of different issues compared to the reduced trial. Primarily, this was a combination of EPA plus DHA. They used corn oil. You've all probably seen in Twitter and all over the place this big discussion whether corn oil or DHA actually have deleterious effects, may increase LDL, may also decrease the absorption of EPA. And bottom line, in this population of patients for primary prevention, there was no reduction with omega-3 compared to corn oil. As you can see here on the primary MACE and the total population, the core MACE either, so absolutely no difference. So should we use it or not? So icosapentaenoic acids are probably the ones that we should use, and not anything else, or that stuff that everybody gets over the counter and spends a lot of money. So really, this trial didn't show that patients that were at high cardiovascular risk, the addition of omega-3 compared with corn oil to usual background therapies had no significant difference in the composite outcome of major cardiovascular events. So in this trial, they do not support the use, at least of this formulation, that again, it's a combination. So probably some food for thought on how we should use this in primary prevention. Lots of stuff going on in heart failure, and we have a strong group here in heart failure that probably know all this data. This is from the omecamtiv mecarbil in chronic heart failure. As you all know, we haven't been very successful in any clinical trial with positive inotropes because of more mortality in these trials. So this is a new molecule. This was presented at the American Heart and published in the New England Journal on the same day. And mostly this is a selective cardiac myosin activator called a myotrope that improves both the cardiac structure and function and decreases heart rate and NT-proBNP in patients with HFrEF. So the Galactic trial enrolled inpatients and outpatients with HFrEF to evaluate this molecule. And these are the key inclusion criteria that had a BNP greater than 125, and you see the data there, managed with a current optimal medical therapy, and hospitalized, or that had urgent ED visit or hospitalization within 1 year prior to screening and that were outpatients. This trial was a 1-to-1 randomization with this molecule that had a starting dose of 25 milligrams BID and escalating dose to up to 50 milligrams BID compared to placebo plus standard of care. Again, big trial, about 8,000 patients randomized, 4,100 to the investigational drug and 4,100 to the standard of care and placebo. Who were these patients? About 66 years of age, mostly white folks with, heart failure event prior to randomization was rather infrequent, only 3%. Lb function that was depressed, around 27%. Most of the patients in class 2 and 3, about 90% of the patients in class 2 and 3, and half of them with ischemic cardiomyopathy, about another 40% with diabetes, and with excellent medical therapies, you can see here on the right, with ACE, ARB, and ARNI, about 90% of the patients, ARNI's 20%, even Sglt2 only about 3%, CRTs 14%, and ICDs about 32%. So a very well treated population. And this had about an 8% relative risk reduction that was significant. It's it's not a huge reduction, but still early on and statistically significant with time to first heart failure or cardiovascular death that was the primary composite endpoint. It had no effect on mortality and a little bit of a delayed effect on first heart failure event. That again was not significant, but at least probably trending towards the right direction and with an improved quality of life as per the Kansas score. Again, subgroups did show that people that had lower LV function probably benefit the most of this molecule. So some new potential inotropic or myotropic, as they're calling them these days, for the treatment of heart failure. Again, this was published in the New England Journal of Medicine. A big influx of Latin American colleagues, a good friend Rafael Diaz in Argentina, Corbalan in Chile, etc. So multinational trial. Victoria trial, another study with another new molecule, led by our friends in Edmonton and the Vigor Center, that actually showed that despite optimal medical therapy, we still have a number of significant risk of death and frequent heart failure hospitalizations in this population. So novel SGC stimulator, Vericiguat, that enhances cyclic GMP pathway was tested. And again, this is the mechanism that I'm not going to get into the details. It's a nice slide. Again, patients with chronic heart failure, class 2 to 4, LV function less than 45%, with guideline-based therapies, and we're having a worsening event. About 5,000 patients were randomized, 2,500 to Vericiguat, and the rest to placebo, and about 2,500 in each arm that were analyzed with complete follow-up. It was very good in this trial, as in most. Again, patients in their late 60s, about mostly male, and with a high-risk heart failure, as you can see by the heart failure hospitalizations in less than 3 months, almost 70% of the patients. With New York Heart class 3 to 4, almost 40% with high NT-proBNP, and with triple guide-based therapy around 60%. And again, about 30% with either ICD or CRT or both. Again, about 10% relative risk reduction in cardiovascular death or first hospitalization. So an absolute event reduction of 4.2 per 100 patient years. So in an early impact, early effect with this molecule. There was no reduction in cardiovascular death, and first hospitalization, again, about a 10% that was marginally significant. And all-cause death or first hospitalization combined endpoint, 10% reduction also that was significant. So another molecule that is a cyclic GMP pathway enhancer that was number needed to treat to prevent one event is about 24, and a population that is considered high risk HFrEF. So again, options we're going to get too many options. I know how we're going to try to use all these medications. Again, empagliflozin, this is the Emperor Reduced trial presented by Milton Packer last year at one of the meetings. And as you know, the DAPA heart failure trial showed some significant improved outcomes in patients with heart failure, with or without diabetes. So the Emperor Reduced was a trial that pretty much emulated the DAPA heart failure trial, enrolled the population enriched with ejection fraction less than 30%, and with an NT-proBNP or a hospitalization due to heart failure within 12 months. Primary endpoint was a composite of cardiovascular death, heart failure, hospitalization. For secondary endpoint was total first and recurrent events. There's a type of analysis becoming more frequent in most clinical trials, particularly today. We were always used to just time to first event, but we know that recurrent events are quite important. And secondary endpoints with all these drugs is trying to preserve the kidney, which turns out to be quite important. Over 7,000 patients were screened, 3,700 randomized, 1,800 to the active investigational drug and 1,800 to the placebo drug. Again, LV function around 27%. Here's a comparator with DAPA heart failure, so pretty comparable. NT-proBNP, a little bit higher than the DAPA heart failure trial. Glomerular filtration rate, again, around 60, which is pretty much the same. And a RAS inhibitor with neprilysin, about 20%. So almost double the amount of the DAPA heart failure trial with excellent background heart failure therapy. Impressive reduction in the primary outcome, time to cardiovascular hospitalization or heart failure, and a very early effect, as you can see here, with about a 25% relative risk reduction in the primary outcome. And you can see that was mostly driven by first hospitalization for heart failure and not necessarily by cardiovascular death. And here's the reduced Emperor total hospitalizations. This is the first secondary endpoint. There was also a 30% relative risk reduction with no alteration in the glomerular filtration rate. So again, actually much better than with the standard therapy and quite stable. So, and the composite renal endpoint would significantly improve, a 50% relative risk reduction and the renal endpoint. So very significant result, no reduction in cardiovascular mortality, but all of the endpoints, the primary endpoint for secondary endpoint and secondary endpoint were all achieved highly significant. So kidney protection also important. So again, 25% relative risk reduction in the composite of cardiovascular death and heart failure. And that was identical to that seen in DAPA heart failure. So of course, already published. And of course, once you got that in the Lancet, you got a meta-analysis of these two trials that basically shows what we already know, a very significant reduction in all-cause mortality, cardiovascular death, first hospitalization for heart failure, and all the other outcomes that you can see here. So very significant reduction, both with or without diabetes in these two trials. So something that we need to look at too. Now again, more with the new molecules like the sotagliflozin in patients with diabetes and recent worsening heart failure, so the SOLOIST WHF trial. And that this is a little bit different molecule because this is a combined SGLT1 and SGLT2 inhibitor, and these are all the trials that have been done. So, and this is more or less the rationale and where to intervene these patients is shown here. So again, sotagliflozin is a dual SGLT1 and SGLT2 inhibitor, which obviously is going to have some kidney protection. This was the main outcome, which was total cardiovascular death, hospitalization because of heart failure and urgent heart failure visit. Again, very early separation of the curves with about a 33% relative risk reduction, which is quite significant, with a numerator, an absolute risk reduction of 25 events per 100 patient years, and one NMT of 4 to prevent 1 event. So very strong results, and again, very early effects by 7 days, you already see the curves significantly separating with, again, about almost a 40% relative risk reduction early on. So interesting data with new molecule that we don't know if it's going to be approved by FDA and Health Canada. And a second trial called the Sglt2 Trial. That's the same molecule in patients with diabetes and chronic kidney disease, which is also quite important. And you can see also about a 26% relative risk reduction, an absolute reduction of around 2%, with a number needed to treat of 54. So very significant results also with reduction in cardiovascular death, non-fatal MI or non-fatal stroke, with again almost a 23% relative risk reduction there, with preservation of the kidney and reduction of HbA1c across moderate and severe eGFR. So again, quite significant and important results. Patients both in eGFR less than 30 or greater than 30, highly significant results. So pooled data of this has been also presented, and I believe this is in press. It's about 28% relative risk reduction, a 3% absolute risk reduction. So an NT of 31 with a very early effects on this population. So yet another dual SGLT inhibitor that will show some interesting results. And here are the combination in patients with also HFpEF, which again, not a lot of molecules have shown anything in HFpEF. This is the pool analysis of soloists and Sglt in about 800 patients with HFpEF. It shows a 37% relative risk reduction in this combined endpoint, which is quite significant. So again, very strong results that patients with these medications and that have type 2 diabetes or should be considered with chronic kidney disease to these molecules. Now, this is making things a little bit difficult. This was sort of an editorial by McMurray and Milton Packer, because, you know, now I don't know how to, when I was, all I know how to use is digoxin and a diuretic and maybe a beta blocker. So this thing has become pretty complicated. This is an algorithm they're proposing on, you know, this is the standard of care right now, conventional sequencing with the different steps. The proposal is that in the first step, you should have a beta blocker and upfront an SGLT2 inhibitor, then angiotensin receptor and a neprilysin inhibitor, and then mineralocorticoid receptor. So again, you probably saw the new guidelines from the ACC published yesterday or the week before, in which some of this is also being detailed. So moving over to ACS, just a couple of trials because I don't have a lot of time to go over a lot of other stuff. But you can see here the Tico Trial. This was published just in November in JAMA. Now the Tico Trial is a randomized, this is a trial conducted in Korea, about 3,000 patients randomized. And again, with this question whether we should reduce the dose of ticagrelor, you know, dual antiplatelet therapy to monotherapy at 12 months. And you can see here that there was a significant reduction in the primary outcome of the net adverse events that occurred about at 90 days. So ticagrelor monotherapy after 3 months of dual antiplatelet therapy. So a very significant reduction, almost a 34% relative risk reduction. And when they look at the landmark analysis at 3 months, again, quite significant. So tendency towards trying to reduce the duration of dual antiplatelet therapy, because as we know, there's always this threat of stent thrombosis and recurrent ischemic events, but with the downside of bleeding, particularly in older populations. So again, this randomized trial pretty much shows that ticagrelor monotherapy after 3 months of dual antiplatelet therapy is safe and reduces adverse events, primarily bleeding, with no net increase in ischemic events. So some good news there from that perspective. And again, the Afib trial, also randomized open label phase 3b trial, Comparing these molecules, because now we have these mostly off patent, comparing this one, ticagrelor versus clopidogrel, in about 1,910 patients that were, these are patients with stable coronary artery disease that were brought for high-risk PCI, where there's not a lot of evidence of what we should do with dual antiplatelet therapy and which one is best. So again, there's a population that about 50% had a history of acute coronary syndrome in the past 12 months, 7% with a previous CABG, previous PCI over a third, peripheral vascular disease, and preserved LV function mostly in this population. And you can see here that they looked at the vasodilator stimulation, platelet reactivity. There's no difference between the two. After the loading dose, there's a higher activity with ticagrelor, with clopidogrel, sorry, and which is in blue, and here at the next morning after PCI. But if you look at the primary outcomes and all the hard outcomes, absolutely no difference at all. And stent thrombosis, myocardial infarction, myocardial injury, and any of the other outcomes. So basically, again, same thing here, showing cumulative events that were low, and there were no significant differences. And as a matter of fact, when they looked at minor bleeding and total bleeding, there was less bleeding with clopidogrel than with ticagrelor. So that's that. I'm not going to get into the ischemia trial because I actually presented that last year. But there's been a lot of discussion on the ischemia trial, whether the definition of MI was appropriate. They've done a number of reanalyses. But again, I don't have the time to dwell with that. But, food for thought that probably clinical trials should use basic definitions. Popular Tavi trial, another trial that was recently presented and published in the New England Journal, looking whether aspirin with or without clopidogrel after Tavi is needed. And again, planned Tavi, about 700 patients, aspirin alone or aspirin plus clopidogrel for 3 months. And these were followed up for a year. And you can see that all bleeding, of course, higher with the combination of aspirin and clopidogrel, and there's no real increase in thrombotic events, almost a 50% relative risk reduction there. Cardiovascular mortality was lower in the aspirin group again, and there was was significant for non-inferiority and marginally significant for superiority with aspirin alone, with a relative risk reduction about 26%, and no difference in mortality, ischemic stroke, or MI. So again, in this population, it is growing. Aspirin alone probably should, after 3 months, should be appropriate. And these are patients that were not on anticoagulation compared to aspirin plus 3 months of clopidogrel. So it reduces the rate of bleeding, and there is no increase in thromboembolic events. So new data there on that population. Let's move to atrial fibrillation, which had a lot of activity this year. And this is the East AFNet trial that was conducted by the European group, East AFNet 4. This is a complex trial, but it is a randomized trial of early rhythm control therapy versus rate control or other therapies in patients with atrial fibrillation. And you can see that there's almost 3,000 patients randomized to rhythm control or to usual care. But you can see here rhythm control that was chosen by each site. There is a lot of differences, like none, antiarrhythmic drugs, propafenone, flecainide, amiodarone, dronedarone, or even AF ablation. And this was, about 8% or 10% at 2 years AF ablation. This is not an AF ablation trial. This is a strategy of rhythm versus usual care, which could be rate control or whatever you want to do. The trial, basically, older patients around 70 years of age. At baseline, half of them were in sinus rhythm, and with atrial fibrillation that was relatively early onset, about 36 median days of onset of atrial fibrillation, with a significant proportion, about a third, that didn't have any symptoms, and about 40% that had had a previous cardioversion. Now, the primary outcome favored the early rhythm control. Again, this does not mean it's favoring AF ablation, but just trying to maintain people in sinus rhythm. So, in contrast with what we've heard from the Affirm and all the other prior trials of almost 20 years ago, well, this trial seemed to show that, early rhythm control had a reduction in the primary outcome compared to usual care. So a lower risk of adverse cardiovascular outcomes with early atrial fibrillation control. So, what I usually insist that, we're born in sinus rhythm, we should die in sinus rhythm. So early approach to try to maintain sinus rhythm is useful. Now, Afib Trials, this is the early AF trial, which was also presented at the AHA, published in New England Journal, and we were part of the trial here, and it was a Canadian trial, basically, that these were patients that were as for first-line therapy, and we'd done previous trials like the RAF1 and RAF2 trials that were small trials that did show that there was an improvement in patients. We treat patients earlier, we think that we're able to prevent the progression of atrial fibrillation. This is the largest randomized trial in AFib ablation for first-line therapy. 300 patients that were treatment naive, so they may have received a beta blocker or calcium channel blocker, but never received an antiarrhythmic drug. 154 were randomized to first-line ablation, 150 to first-line antiarrhythmic drugs. All the patients received an implantable loop recorder, and they had daily transmissions throughout the follow-up, and also quality of care and indexes. Now, it's a relatively young population, which is what we see, paroxysmal atrial fibrillation. 2/3 were men, lots of hypertension, sleep apnea, and obesity. And AF was significantly symptomatic, 1-year median duration from first AF diagnostic. 40% had had a previous cardioversion, and there was severe impairment in the baseline QOL scores. And again, 57 years, obese patients, about 40%. So, which, we are doing some studies here and trying to do some multidisciplinary care in patients with obesity, hypertension, et cetera. And you can see that's the typical population for this. What was used? Well, flecainide was primarily the drug that was used most. Some propafenone, sotalol, very little dronedarone, and amiodarone, very few patients. So again, for first-line therapy, younger patients probably are not going to be using a lot of amiodarone. And this was with cryo balloon. So this was not radiofrequency ablation. This was with the balloon, because already shown with cryo, with radiofrequency, that this works. Now, about a 50% relative risk reduction in time to recurrence to any atrial tachyarrhythmia. So about a 25% relative risk absolute risk reduction, sorry. So number needed to treat of only 4, and absolute reduction also in secondary symptomatic atrial arrhythmias of around also 60% almost, which is quite significant, with a number needed to treat between 6 to 7. And again, marked reduction in all of the primary and secondary outcomes. So a very positive trial that further advances the knowledge that early AF ablation in patients with paroxysmal atrial fibrillation, is not for everybody, but this is very good data from our Canadian sites, and we participated here also quite actively. Second study, also these 2 studies were published back-to-back in the New England Journal, same edition, from the group from the Cleveland Clinic that did the Stop AF first trial. Same kind of population in which ablation showed significantly being superior to antiarrhythmic drug therapy as first-line therapy. In similar population, this study did not have an implantable loop recorder, but similar findings to our trial. Now, last but not least, obviously, we have the issues with COVID. I just looked at this last night, and you can see here that if you just put COVID in cardiovascular, there are almost 5,000 publications within the year 2020, because there was nothing before that. So obviously we were overwhelmed by COVID in a lot of stuff. We know that there was myocarditis, and there was some proposed guidelines on why this happens. All the story with the spike protein, the ACE2. Remember that there was a lot of noise about at the beginning, should we continue people on ACE and ARBs or not? And a lot of issues with acute and chronic SARS-CoV-2 infection that can induce cardiomyocyte injury, pericardial inflammation, microvascular ischemia, etc. And this lead to brady and tachyarrhythmias that we've seen some of these with a bunch of alterations that we've seen in MRIs and other places. And some algorithms that have been proposed by some, that if you have a suspected myocarditis with these symptoms, then you do these tests, there's your differential diagnosis and investigations, and how do we manage this? Now, this also had some impact on out-of-hospital cardiac arrest response. The responses were delayed, survival was also reduced, and bystander CPR was reduced during this COVID pandemic because of obvious reasons. We also saw, and Mama's presented some of this at rounds last year, showing that, of course, we did have some later presentations with STEMI and other issues there. There were cerebrovascular complications because of COVID-19 also, and lots of them insignificant with prothrombotic state. Not going to get into too much detail here because you know that the Attack Freedom COVID trial is being done, and we are going to participate here in Calgary. And next week we have Mike Farku presenting on this. So it's a randomized trial that's ongoing, led by the people at Mount Sinai, both in Toronto and in New York. And it's an interesting trial in which they're going to compare full dose low molecular heparin against apixaban and usual care for a number of weeks. So we'll hear a little bit more about that. The story about whether we should suspend angiotensin converting enzyme inhibitors or not. Good friend Renato Lopez conducted this trial called the BRACE Corona trial that was presented at ESC and published. Again, multi-center phase 4 trial, randomized almost 700 patients to temporarily suspend ACE or ARBs for 30 days or continue ACE or ARBs with a primary outcome of days alive and out of hospital at 30 days. This was, again, one of the good things of Corona, that we've been able to expedite these protocols and get them done in a relatively short period of time. And again, almost 1,300 patients were screened and 659 randomized to the two different groups. And this is the population that was randomized, basically, with ACE inhibitors, most with ARBs, actually 80% with ARBs. And you can see there the different clinical characteristics of the population there. There's absolutely no difference in the group that's suspended in red or continued in green during the follow-up of 30 days after randomization. So a negative trial of providing further support that we should continue on these medications. No difference in all-cause mortality, which is overall low within the context of the trial. So again, this was the first trial to show that there was no issue with that. As you know, there's a lot of noise about this, whether we should or shouldn't stop this. Again, COVID created a lot of dissent. This trial that was published in Annals of Internal Medicine, the editors took a lot of beating for publishing this. That was the effectiveness of adding a mask recommendation to other public health measures to prevent SARS in the Danish mask wearers. Again, this was a randomized trial, and the conclusion was that to wear masks to supplement other public health did not reduce SARS-CoV-2 infection among wearers by more than 50% in the community with modest infection rates. Again, all these things go to press, so CNN, a bunch of people say, oh, so maybe Fox would say, well, you see, we shouldn't be wearing masks. But this is not what the trial was looking at, because this was you know, not in the community. So again, misinterpretation of the information. Other things that, you know, now we learn that, oh, we're racist, and that actually, you know, healthcare access is not as good. I already knew that. We didn't, but we needed COVID basically to create these policy statements that, oh, well, you know what, we're not doing that good. And it's not only happened in the States, it's happened all over the world, where we've seen that there's a lot of inequality across the world, and pandemics like these just highlight those issues. Big story with chloroquine, big mess with this, and until to the point that, you know, politicians were able to pressure scientists and mostly the regulatory agents to provide, you know, temporary approvals for some of these things, and then randomized trials, small and large, didn't show any effect. As a matter of fact, more danger with these. Now, the recovery trial and the recovery group has probably shown the better evidence of the few things that work, like dexamethasone, and of course, research in the context of the pandemic. And the good news, we've got 3 different vaccines out there within a year, which is quite remarkable. And so there's some good stuff after this, but there's no doubt that we have deconstructed science. There's been retraction of, you know, big multinational registries of both for hydrochloroquine and for the ARB ACE inhibitor things that, you know, should not happen. Hastiness from the part of editors. You know, we all wanted responses and answers pretty early on, but, you know, hastiness is never good. It just leads to an appropriate interpretation of science. And then, you know, the appropriate trials have shown that really there's no difference between hydroxychloroquine and placebo. But there's still people that out there are treating patients with this and advocating this. So, geez, I went through 110 slides faster than I thought I was going to go. So that was my cardiology in review. I missed the W because there's still stuff going on this year. But again, you know, lots of stuff going on. And I don't know if other people feel that there's other trials that I have missed, or other comments you may have for what happened this year. So I will leave it at that. Any comments? All I hear is silence.
It's the intervals here. It's great review, a little dizzying, but great review. But in your opinion, what are the 3 major trials, if you want, and things that impact practice now?
Yeah, it's a good point. I think the Sglt2 story is quite impressive. I think that's very important. I think also the polypill data, again, bringing aspirin back to the front is important. You know, aspirin is a very cheap intervention, which, you know, there's a lot of patients that have stopped the aspirin because of all the news we had in 2018 from the different trials. And I think that also a little, well, you know, I'm biased towards atrial fibrillation and ablation, but I think that we've come to the point that we've come to realize that we have sufficient evidence to show A, that it is a safe procedure, and B, that the earlier we intervene in these patients, the better. We got to the point in which we thought that, you know what, rate control is fine, leave people in atrial fib. If they have a controlled AFib, that's absolutely okay. That is not true. These people end up having heart failure, stroke, and die more. So I think it's important that this definitely changes that. So that would be my kind of 3 pointers. But of course, other people would disagree. I don't know, some of the other people out there, Mitch or some of the interventional cardiologists, what do you guys think?
Carlos, it's Todd. Can I ask a question?
Sure.
So the one trial that you didn't mention relates to post-MI care or even chronic coronary disease care with colchicine as an anti-inflammatory. Both the Colcott study that was done by the interventional group here and Lodoco 2 have shown pretty impressive reductions in events, pretty consistent across a range of chronic and acute patients, very cheap, very safe. So I would like some input from those that deal with coronary disease a lot or interventional cardiologists in terms of whether they're starting to implement this. I know it hasn't reached guidelines yet, but I've been personally impressed by that data. So I would like some input from you and others about what they think about colchicine.
Yeah, true. I did last year. I think I talked about that one because it was presented at the end of the year. But yeah, that's a huge input. There's other trials like the Clary Synergy, the one that Sanjit is conducting. That's going to be a larger trial, but I think that's very important. I don't know if that has been adopted in clinical practice, and I'll leave Dean and the others to talk about that.
I think with the publication of the Australian trial too, showing that in stable coronary artery disease, there's an effect. Like Todd, I'm quite impressed. And I actually started using it in some of my patients.
Yeah, I think that's a very important intervention also, particularly in stable CAD. Any of the other interventionists around or any other comments there?
Yeah, it's Brian. So like Dean as well, I've started prescribing colchicine, in particular for patients that are, higher risk of recurrent events. I mean, like those are the ones that are going to benefit the most, or the people that as well that are super keen that keep asking, hey, is there anything else I can do? Is there anything else I can do? And then it, kind of comes up, but it's not yet guidelines. They'll start them on colchicine.
So when do you start it and what doses are you using? What are you doing with the aspirin and the PGY12 inhibitors? Do you change the doses? Give us a little bit of insight on that.
Yeah, so usually I've been starting them more in my chronic CAD patients, but certainly based on those trials, we can start them acutely from Colcott. So in terms of the aspirin and the PGY12, it has no impact on that because the colchicine is mainly an anti-inflammatory rather than a antiplatelet. And I've been starting them, based on what's available in Canada. I've just been putting them on 0.6 milligrams once a day.
Okay. Well, yeah, I do think that the heart failure area has really changed. So maybe with some of our heart failure guys have any comments on how are we going to deal with all these drugs, and do we know if the molecule used in SOLIS is going to be approved by Health Canada? Any comments there? I don't know if Jonathan, Nicole, Brian, any of you guys are there?
I think, Carlos, your comments are right on. The field is exploding, and you see that in the way that other people, are accepting of the evidence and how they're willing to change. So, in hospital, having just completed a week of service, I can tell you that the people, others are paying more attention to, a markedly different titration scheme than previously. And so it's really in patients with low ejection fraction, it's really a very, very different environment now than it was even a year ago. So I completely agree with you. It's changed quite dramatically, and likely will continue to change over the next year as well, because we have a completely different initial approach, and then there's also several more options after that as well. So it's a growing field. For those of you who are still in training, it's a great place to learn your craft.
So should we discharge from hospital all these patients on an SGLT2 inhibitor?
Well, and there's several other heart failure people on, so I would encourage them to speak up. But that is what we're seeing. And not only that, but what we're learning about inpatient care is that not only do people tolerate more than one change while in hospital, they actually do better. The earlier that evidence-based therapy is administered. So it's it's almost like a positive reinforcement once you get things started early. It seems that with the adoption of SGLTs, that has kind of broken the dam, and now people are willing to, they recognize that there is a fundamental change in the way things are gone. So we are planning to, the heart failure group has looked at and has vetted a newer titration scheme that we're going to promote to the rest of not only the division but to everyone else. And all I can say is stay tuned, because more will come on that. It's led by it's not just the Jonathan Howlett show. It's Nicole and Noel and Rob, who you'll see a lot more of in the future. So stay tuned.
I just want to jump on Jonathan's comment about starting SGLT2s early. Just to advertise, and I'll be presenting at Ground Rounds in a couple of months. We are going to take part in a Sglt2 trial in patients with acute MI with LV dysfunction. So this is one of the studies that Jonathan's group and the interventional group had divided up. We felt this was more for the interventional group because it was an ACS population, but we're going to be looking at an early start for SGLT2 patients after a big acute MI. So stay tuned. It's another CVC, Canadian Bigger Center-led trial.
Yeah, great. Lots of stuff coming there.